mic ल्याउन भने So today we are going to continue our discussion on respiratory physiology. Continuation of respiratory physiology. Okay, we're talking about first factor, that is a compliance. Okay. There are many factors. First of all, I told that there are some factors, forces acting to collapse the lung, and forces preventing to collapse the lung. Second are the forces preventing to collapse the lung. Okay, to collapse the lung. Forces acting to prevent the collapse of the lung, and force preventing to collapse of the lung. First factor we have read about the compliance. Okay. Now second factor I will like to focus on is a surface tension. Okay. Surface tension is a force which tend to collapse the lung. It's a force which tend to collapse the lung. Okay. So compliance of the lungs helps to it is a factor which prevent the collapse of the lung, whereas the elasticity will try to collapse the lung, whereas the compliance will try to prevent the collapse of the lung. And the surface tension is another important force, very important force, which helps to collapse the lung, which usually tends to collapse the lung. So surface tension is exerted in any air fluid interface. Okay, in any air fluid interface we have the surface tension. Suppose we have a beaker of water, then in the surface we have surface tension. That was the reason why we read in physics that our raindrops are spherical. Okay, because of the surface tension. Okay. Same concept applies in the lungs too, because in the lungs we have air. This is the air interface. This is the air from the atmosphere, and these are the fluid. Okay. So in the alveoli also we have the surface tension, and this surface tension tends to collapse the lung, collapse this alveoli. So to counteract the surface tension, the nature have made a molecule that is called surfactant. Okay, what this surfactant basically does is that it hinders the air and air-water interface. Okay, suppose this is an air-water interface, so surfactant molecules are implanted in the air-water interface, and thus it will reduce the surface tension. So surfactant molecule will reduce the surface tension. The main component of the surfactant molecule is a phosphatidyl choline. Okay. So main component of the surfactant is a phosphatidyl choline, and this surfactant will reduce the surface tension. How do we know that a surfactant reduces the surface tension? First of all, there are experiments done, and that have proved us that that it reduces the surface tension. And second is by the clinical application of the disease, clinical applications. Okay, like in case of respiratory distress syndrome. Okay, respiratory distress syndrome, like in hyaline membrane disease. Okay, hyaline membrane disease, HMD, hyaline membrane disease, or respiratory distress syndrome, which happens in the infants and the children lacking the surface tension, surfactant, and when there is less amount of surfactant, then there will be the more of the surface tension, and thus the lungs tends to collapse. Okay, their lungs tends to collapse, and these are the diseases. This is a disease which happens in the infants born preterm, preterm, because the surface because the if the surfactant molecule, because if the child uh, uh, is given birth before his or her lungs develop the surfactant, then this alveoli tends to collapse, and uh, thus the surface tension increases and this alveoli tends to collapse. Okay, similar disease in the adults is acute respiratory adult respiratory distress syndrome, in which the surfactant is lacking. Okay, but we cannot just put the synonym on high membrane disease and adult respiratory distress syndrome as the counterpart of the children and the adults, because there are mainly the type 2 pneumocytes which are involved that in the high membrane disease, but in the acute respiratory syndrome type 1 pneumocytes are also involved. So another one disease, important disease, the adult respiratory distress syndrome, where we can see that the surfactant is a very important component. Okay. Now let us talk about the another important concept about the surfactant. Suppose this is a graph. Suppose this is a graph. Okay. This is a compliance graph. Okay. Suppose this is a normal compliance graph, our lungs compliance graph. If the surface tension decreases, then the compliance decreases. Surface tension decreases, then the compliance decreases, because our lung alveoli cannot distend easily. So the compliance decreases if the surfactant molecule decreases and the surface tension increases. Suppose okay, this is the curve with no surfactant molecule, no surfactant. So what this graph basically means is that if we have no surfactant in our lungs, then it is very hard to distend our alveoli. Okay, because so much of pressure is needed to achieve a certain volume. Okay. This is what basically this graph means. Now, now how this surfactant helps to prevent the collapse of the lung? How surfactant helps to prevent collapse of alveoli. Okay. Uh, in the lungs, we have small alveoli, and the larger alveoli. Okay, and they are connected. So we have smaller alveoli, larger alveoli, smaller alveoli, larger alveoli. Okay, so applying the Laplace law. Okay, Laplace law is pressure is directly proportional to tension. Pressure is inversely proportional to radius. Okay, so what this equation means that the collapsing pressure is inversely proportional to the radius. That means if we have lesser radius, then the collapsing pressure is more. So if we don't have any surfactant molecule, then this smaller alveoli, because having the lesser radius, will have more collapsing pressure and they will collapse. Smaller alveoli will collapse. Whereas the larger alveoli, as they have the bigger radius, they won't collapse. And what will this do is that these small alveoli and larger alveoli are in communication with each other normally in our lungs. So these will collapse and this won't. So the pressure is higher here than here. So air will move from the smaller alveoli to the larger alveoli, and thus the smaller alveoli will become more and more smaller. They will collapse and collapse. Whereas the larger alveoli tends to become larger and larger. Okay. This is the will be the clinical picture if we don't have the surfactant molecule and we have the surface tension in our alveoli. But but then how these surfactant molecules which are made by the nature helps us to cope with this problem? Okay. Okay. What this surfactant will do is that the amount of surfactant is constant. Okay. For a particular alveoli, the amount of surfactant is constant. So if we have a small alveoli and a larger alveoli in communication with each other, then the concentration of the surfactant in the smaller alveoli will be more. So concentration of the surfactant concentration will be more. Whereas in the larger alveoli, the surfactant concentration will be less. So surfactant concentration will be less in the large alveoli. So uh, what is the consequence of this? Because of the large amount of surfactant, because the surfactant are highly concentrated in the small alveoli, so surface tension is less. Whereas in the large alveoli, the surfactant concentration is less, so surfactant is relatively more, and this will help to prevent the collapse, because as the surface tension is less in the smaller alveoli, so they won't collapse. Okay. Whereas in the larger alveolar surface tension is little higher, so they tend to collapse a little, and this will create a stability in the alveoli. So the stability in our lung system is mainly achieved by the help of surfactant molecule. So surfactant is a very important molecule, and it is the prime determinant of the lung compliance. Okay, the prime determinant of main determinant of the lung compliance. Now, third factor I would like to talk about is the resistance. Okay, resistance. This is a resistance resistance in the airways. Okay, this airways resistance in the airways is another factor which resists the lung to expand. Okay, so this is another factor which resists the lung to expand. That is the resistance in the airways. As we have always we have known that the resistance is inversely proportional to the radius. Okay, that means the larger the radius, the smaller the resistance. Okay, but in our lung, the largest resistance is offered by larger and smaller airways, larger and medium airways. So how do I explain this concept that the resistance in the lung, in the airways, is maximum in the larger and smaller airways, because this does not go with this theory. So what happens in these large and medium airways, is another thing, that is the increased turbulence. Okay, so these larger airways and small medium airways have more turbulence. So this turbulence will increase the Reynolds number, and thus it will offer more resistance. So the resistance is higher in the large and small airways. So resistance is another important factor in determining the lung collapse or the distensibility. Okay. Now, as we have known about all these factors, surfactant, compliance, and resistance, now I would like to talk about the another important concept about how we have understood some of the lung mechanics, and if I have missed some out, then I will just corporate them. whenever I get the time, whenever there is some need, then I will just incorporate the concept, or else I think I have incorporated everything uh, about the long mechanics. Firstly, uh, now let's talk about the another important concept, that is the, I think I have missed one graph. Okay, I will just incorporate this graph into our discussion, then we'll just move on. Okay, suppose this is another important graph for the USMLE. So this is a normal long compliance graph. Okay, these are the volume, this is the volume. Okay, this is the flow. Okay, so what this graph basically means is that in the normal long, when there is a normal long compliance, there is a normal inspiration, then there is expiration. Okay, but what happens in the case of obstructive and the restrictive lung disease? Okay, we have to incorporate two concepts about the restrictive and the obstructive and restrictive lung disease. Okay, from zero, suppose this is zero volume, then we go on increasing 1, 2, 3, 4, 5, 6. So from this graph, this is a case of obstructive disease, this is a case of restrictive disease. How do I know it? Because uh, if I see the residual volume, this is the initially is the residual volume, because in our flow volume loop, okay, we had this graph, same graph. Okay, this is the residual volume, and this is the total lung capacity. Okay, so same graph. Okay, so same graph, suppose this is a normal, then if I plot here and if I plot here, what this basically means is that residual volume in this graph, the residual volume is less, the total lung capacity achieved is also less. So this is a graph of a restrictive lung disease, whereas in this graph I can see that the residual volume is high and the total lung capacity is also high. So this is a graph of obstructive lung disease. Okay, so this was the graph I wanted to incorporate. I think I had missed that, so I just incorporated this on the important graph in our discussion. So now let's go to the, as we have understood about some of the lung mechanics, then now let's go with the gas exchange. Okay, gas exchange principles in our alveoli. First thing I want to incorporate is the partial pressure of gas. Partial pressure of gas. So what basically is the partial pressure of gas? Partial pressure of the gas is the fraction of the gas into atmospheric pressure. Okay, so this is the partial pressure of the gas. So suppose the partial pressure of the gas for the oxygen 21%. Our oxygen is 21%. So we have the partial pressure of the gas, fraction of gas 0.21, and we have 760 mmHg. So that means the partial pressure of the oxygen is 160 mmHg. This is the first thing I want to incorporate, that the partial pressure of the gas is that is the oxygen, is 160. But second thing I also want to incorporate is that this fraction of the gas, this gas which we have, this atmospheric gas, there is some humidity in the gas, because as we take the gas, there is some humidity, and this some humidity is also gained by the some partial pressure is also due to the humidity. So to calculate the actual partial pressure of the gas, like fraction of the gas, partial pressure of the atmosphere minus humidity. So we should subtract the partial pressure of the humidity, that is partial pressure of water. Now if we do this, then we have 0.21 into 760 mm of Hg minus the partial pressure of humidity, that is the 47. Now if I calculate this, then it becomes 150. So this is the reason why we use 150 mm of Hg in our standard textbook for the partial pressure of the oxygen. Okay, partial pressure of oxygen we take 160, 150 because that is the amount of gas we incorporate in our alveoli. So suppose this is the alveoli. Okay. So I have known that over there is the 150 mm of Hg partial pressure of the alveolar gas in the alveoli. That is partial pressure of oxygen. So this is the venous side. This is the arterial side. Or let me say that this is the pulmonary artery, vein. Okay. These are the capillaries. So when the oxygen in the pulmonary artery basically carries the less oxygenated blood, so the partial pressure of oxygen here is less, that is 40, whereas the partial pressure of carbon dioxide is 47. Okay, in our alveoli, because initially we have partial pressure of oxygen, that is 150 mmHg, but when it reaches the alveoli due to some resistance and due to the continuous intake of the oxygen, so it becomes 100 mmHg. So that is the reason why we say that the partial pressure of oxygen at the alveoli level is 100. Now partial pressure of carbon dioxide, let me see, carbon dioxide here is 40. Okay, 40 mmHg. So let me say that all these from the principle of diffusion. As this blood passes through this alveoli, then because of the pressure gradient, the oxygen here will become, partial pressure of arterial oxygen is 100. So I can say that this is very important concept, because I can see that the partial pressure of alveoli, partial pressure of oxygen in the alveoli and partial pressure of arterial oxygen is the same. Okay. We also need to remember that all the carbon dioxide in the alveoli is from our body, our own body. Okay. So partial pressure of oxygen carbon is 47. It diffuses outward, so it becomes partial pressure of carbon dioxide at the arterial site will become 40 mmHg. So this is how the diffusion in our alveoli occurs. So we can see that the partial pressure of oxygen, gradient for the oxygen is much more higher, that is from 40 to 100, whereas the partial pressure of carbon dioxide gradient is much lesser, that is from 47 to 40. But also the carbon dioxide diffuses easily, because this usually happens because the carbon dioxide is more soluble and it dissolves in the plasma. So because of the solubility of the carbon dioxide more, so that the partial pressure of carbon dioxide is although the gradient is less, but it diffuses easily. Another concept I want to impose is that the partial pressure is determined by the soluble gas, okay? Soluble gas, and not the bound. This concept I want to impose because the partial pressure of oxygen is determined by the amount of oxygen amount of oxygen dissolved in the plasma, not not by the not by the oxygen bound to hemoglobin. Okay, so this is an important concept I want to impose. So if I want to if I want to maintain a partial pressure of oxygen, so then the main factor is the amount of gas dissolved. Okay, amount of gas dissolved. So this also means that the amount of oxygen bound to hemoglobin does not significantly affect the partial pressure. Okay. Okay. Uh, this concept. So now let us study about the factors affecting the partial pressure of carbon dioxide. Okay, factors affecting partial pressure of carbon dioxide. So what are the factors? First is the solubility. Okay, solubility of the carbon dioxide that will help in the partial pressure carbon dioxide to dissolve, and second is the gradient. Okay, that is the partial pressure of carbon dioxide. Another important factor which determines the partial pressure of carbon dioxide is the minute carbon dioxide minute ventilation and carbon dioxide production. As we have discussed that all the carbon dioxide comes from the metabolism, so the amount of carbon dioxide produced determines the partial pressure of carbon dioxide. Okay, and the minute ventilation also determines, because if we have more ventilation, that is hyperventilation, then we wash out the carbon dioxide, and thus the partial pressure of carbon dioxide goes down. Whereas if we hypoventilate, then the carbon dioxide is retained, and thus the partial pressure of carbon dioxide also goes up. So that is the minute ventilation, how it affects the carbon dioxide concentration. Second is the carbon dioxide production. Okay, that also affects the carbon dioxide production. Now I would like to talk about the factors affecting the partial pressure of oxygen. Okay, what are the factors that affects the partial pressure of oxygen? We have already discussed that the partial pressure of oxygen is determined by the amount of the oxygen into atmospheric pressure. Okay, same applies. The amount of oxygen, if I have less amount of oxygen in the atmosphere, then that will my partial pressure of oxygen will be less. If the atmospheric pressure is less, like in the height and altitude, then also the partial pressure of oxygen is less. Okay. So now I would like to talk about the factors affecting the diffusion. So what are the factors that can affect the diffusion? Suppose this is the alveoli. This is the alveoli and blood vessel interface. So what are the factors that can affect the alveolar diffusion? First is the surface area. This we basically know that if the surface area is more, then the diffusion is more. Okay, this is clinically important, like in case of emphysema. Okay, emphysema cases, like where the septa are destroyed and the surface area is reduced, and thus we have the lesser diffusion. Okay, surface. Second is the thickness of this interface. This is very clinically important in the case of the restrictive lung disease, basically sarcoidosis, pulmonary fibrosis. In these cases, the alveoli and blood vessel interface is thickened. That's why the diffusion is less. So this is another important factor which affects the diffusion. And third important factor is the concentration gradient. Okay, concentration gradient. As we have known that the gases flow from the higher concentration gradient and towards the lower concentration gradient. Okay. So that these are the factors which determine the diffusion of the oxygen. Now, another important factor, important discussion is the diffusion capacity of the lung. So, suppose I have to calculate the diffusion capacity. What is the diffusing capacity of the lung? Then I use, this is called DLCO. Then I use carbon monoxide. Carbon monoxide for this purpose. Why do I use carbon monoxide to calculate the diffusion capacity of the lung? The main reason is that we have seen that the partial pressure of oxygen and the partial pressure of carbon dioxide is diffusion limited. Diffusion limited. That means this is the alveoli and this is the blood vessel, and we have the partial pressure of alveoli, that is 100, partial pressure of carbon dioxide, that is 40, and that will be the same in the arterial side, that is the pulmonary vein. So this is called the diffusion limited. But DLCO, but carbon monoxide does not follow the diffusion limited. That means even if there is no concentration gradient, it keeps on diffusing. It keeps on diffusing. We have seen that oxygen and carbon dioxide diffuses only when there is concentration gradient, but the carbon monoxide can diffuse even if there is no concentration gradient. And this is very important for us to know about the diffusion, because so this is the reason why we use the carbon monoxide for calculating the diffusing capacity of the lung, that is called the diffusing DLCO, diffusing capacity of the lung. Okay. I think I have covered about some of the factors: partial pressure, oxygen, partial pressure, carbon dioxide, and diffusing capacity. Now we'll learn how the oxygen is transported in our system normally in our blood. Okay. Okay. So how the gases are carried in our system? Okay. First, oxygen. Okay. As I have mentioned that the oxygen can be carried in the form of dissolved form. Second, hemoglobin bound form. Okay. Uh, Hemoglobin bound form is the main form in which the oxygen is carried, whereas the another important form is the dissolved form. Why dissolved form is important? Because it determines. I have just acknowledged you that it is the dissolved form which determines the partial pressure. Okay, partial pressure. So what this means is that although if I have anemia, if I can have polycythemia, that means my hemoglobin can go down, hemoglobin can go up. This will decrease my oxygen content. This will decrease my oxygen content. This but my partial pressure of oxygen can remain the same. May remain the same. Usually remains the same. Although in case of anemia or polycythemia, partial pressure of oxygen doesn't go much difference. Okay, because it is the dissolved form of the oxygen which determines the partial pressure of oxygen and not the hemoglobin bound form. So we have one graph. This is the partial pressure of oxygen in the blood, and this is the oxygen content. Okay, partial pressure of oxygen is what determines the partial pressure. Dissolved form is what determines the partial pressure of oxygen in the plasma. Okay. Now, second form, very important form in which the oxygen is carried is the hemoglobin bound form. We call it oxyhemoglobin form. Hemoglobin is a tetramer. Okay, is a tetramer. It has two alpha subunit and two beta subunit. Okay, alpha subunit and beta subunit. But hemoglobin is a one molecule it is a protein, basically a protein, which follows a principle of cooperativity. Okay, what is the principle of cooperativity is that whenever I try to load a hemoglobin with oxygen, if all the pockets of the hemoglobin are unfilled, then it will be very hard for me to put the oxygen in it. But if I have loaded in one pocket, then it will be easier for me to load in second pocket. If I have loaded in two pocket, then it will be much easier to load in third pocket. So that means it follows a principle of cooperativity. That means it is very easy if I this is the reason, this is the main principle behind the sigmoid nature of curve in the hemoglobin curve. Okay, hemoglobin dissociation curve, we have a sigmoid nature of the curve. This is because of the cooperativity nature, because initially it is very hard to load the oxygen. Okay, that is seen here. And then when the oxygen is loaded, then it is very easier for us to load the oxygen. That is, it is very easier for us to load the oxygen. This is seen by the this part of the curve, hemoglobin dissociation curve. So suppose I have to calculate the content of the oxygen. Okay, content of the oxygen in the hemoglobin. Then I know that 1 gram of hemoglobin carries 1.34 ml of the oxygen. Okay, so the amount of hemoglobin, the amount of hemoglobin in the grams determine the oxygen content of the blood too. So content of oxygen is basically determined by two things, that is the one bound to the hemoglobin and second dissolved in the plasma. In this case, I will also like to emphasize about the graph of the myoglobin, okay, which is a rectangular graph, because it does not follow the principle of the cooperativity, whereas the hemoglobin dissociation curve follows the principle of the cooperativity. Now, let us learn some important concept about the about the P50 oxygen dissociation curve. Uh, okay, oxygen dissociation curve, oxygen hemoglobin dissociation curve. So this is basically a graph, sigmoid nature of the graph. Okay. So here I have the partial pressure of oxygen, and here I have the hemoglobin content. Uh, here we have to learn about the concept of P50. P50 is the amount of is the partial pressure of oxygen. Partial pressure P50 is defined as the partial pressure of oxygen at which hemoglobin is half concentrated. That is, it is 50% concentrated. That is the partial pressure. So suppose this is the oxygen partial pressure of oxygen 0, 20, 40, 60, 80, 100. Okay, partial pressure of oxygen goes to 100, and this is the hemoglobin content. Suppose this is 0, 5, 10, 15, 20. Suppose this is the P50, that is at partial pressure of 50. Okay, the amount of hemoglobin saturated this. Okay, this is called 50. Okay, at 50% of partial pressure of oxygen, at 50%, at the partial pressure, the 50% of the hemoglobin which is saturated, that is sorry. So half of the concentration of oxygen or hemoglobin, let us take 10. Then suppose the partial pressure of oxygen at which the 50% concentration of hemoglobin occurs is this. So this is called the P50 in this section. Okay. Now we have the concept of left shift of the curve and the right shift of curve. Left shift. The right shift of the curve. This is a left shift. This is a right shift. Okay. So if I have the left shift of the curve and if I have the right shift of the curve, so then what it basically means? Suppose if I have the left shift of the curve, that is more of the left shift of the right shift of the curve, then the amount of hemoglobin I will release is more. So that is, if I have more temperature, if I have more carbon dioxide, if I have more 2,3 BPG, okay, if I have more H plus, my unloading of the hemoglobin will increase. Okay, that means the right shift will unload the hemoglobin, where the left shift of the curve, left shift, I will bind the hemoglobin more tightly, bind the hemoglobin more tightly. Okay, like if the temperature is less, in the case of hypothermia, if carbon dioxide concentration is less, then if the my 2,3 ppg is less, okay, in case of H plus less, or in case of fetal hemoglobin, there is the left shift of the curve, that is I cannot unload the hemoglobin. So the right shift of curve basically means the unloading of the hemoglobin, because I can see that at lesser partial pressure, in the, if I have the left shift of curve, then at the lesser partial pressure also the hemoglobin is 50% saturated. Whereas if I have the right shift of curve, then the amount of partial pressure I need to unload is less. So that is the shift to the right and shift to the left. Okay, that is right unloads and left loads the hemoglobin. So uh, we have anemia. We have three things. Suppose this is the normal hemoglobin curve. Okay, normal hemoglobin curve. Second, we can have anemia or the polycythemia. Okay, that is oxygen content can increase, oxygen content can decrease. Okay, that is anemia or the polycythemia. These are the two things that can happen in the hemoglobin curve. So I think I have made this clear about the oxygen distribution curve. It is very easier to remember. If there is a right shift of the curve, then it is easier to unload, and if I can unload, then it will be more easier for the tissues to extract. Whereas if I have the left shift of the curve, then the hemoglobin is bound more to the oxygen tightly, and I cannot unload, and the tissues cannot extract the oxygen. Okay. Uh, Now let's talk about the transport of carbon dioxide. Transport of carbon dioxide. Carbon dioxide is also transported in the one is the amino forms, that is carbamino compounds. Carbamino compounds. Second is the dissolved form of carbon dioxide. Third and most important form of the carbon dioxide is the bicarbonate form. And I think I will explain this bicarbonate form in much more detail. Okay, suppose this is the RBC. How this carbon dioxide will be transported? Suppose this is carbon dioxide. Carbon dioxide is soluble, so it crosses the wall, and hemoglobin. Carbon dioxide will bind to the hemoglobin. In with the water, then it will form the carbonic acid in the presence of carbonic anhydrase. This carbonic acid will be dissociated, will be dissolved into two forms, that is H plus proton and bicarbonate form. This bicarbonate will return to the circulation. Okay, bicarbonate will return to the circulation, and we have the only H plus form. This H plus form will be bound to the hemoglobin, and this is how the carbon dioxide is basically transported in the RBC. But we can see that as the bicarbonate leaves the RBC, then there is the equilibrium. Equilibrium is disturbed. Equilibrium of the charges is disturbed. So to counterbalance this, counterbalance the charges, what happens is that the chloride will come inside the RBC, and this is called the chloride shift. This is called the chloride shift. Okay, so to counterbalance the because the bicarbonate has left the RBC, so there is only a proton left inside the RBC. So to counterbalance this effect of as the negative charge has gone out, so a negative charge should come in to balance all the amount of charges. So a chloride will come inside, and this is called chloride shift. And this is what happens in the level of tissue. So in the level of tissue, the tissue will release the carbon dioxide. Carbon dioxide will bound to the water, and it will form the carbonic acid in the form of in the presence of carbon anhydrase, and it will split into the H plus and bicarbonate. Bicarbonate will leave the circulation to counterbalance the charge. Chloride will come inside, and H plus will and this proton will be bound to the hemoglobin, and this is how this RBC now goes to the alveoli. What happens in the case in the alveoli? In the alveoli, just opposite happens. That means that the hemoglobin and H plus this hemoglobin and H bicarbonate will again come from outside the circulation into the RBC, and this will bind with the hemoglobin with the H plus. H plus will form the bicarbonic acid. Carbonic acid will combine to form the carbon dioxide and water, and this carbon dioxide will go into the alveoli. So in the tissue and the alveoli, just opposite happens. So in the alveoli too, as in the tissues, the chloride shift was inside the RBC to balance the charge. So, but in the alveoli, the bicarbonate came, so the chloride shift will be outward. Okay, this is the only thing I want to impose, that the shift of the chloride. Okay, inside and outside, in the tissues inside, in the alveoli outside. It is all to balance the charge, because in the alveoli the bicarbonate has came back, so the chloride needs to go out to balance the charge. Okay, this will form carbonic acid, and it will form water and carbon dioxide will leave the alveoli. Okay, this is how the transport of the carbon dioxide mainly happens in our circulation. Okay, now I would like to talk about a little about neural regulation, how our respiration is regulated. Okay, we have two type of chemoreceptors: central chemoreceptors, and peripheral chemoreceptors. Central chemoreceptors and peripheral chemoreceptors. Chemo means chemical. They respond to some chemicals. So central and peripheral chemoreceptors. So now let us talk about the central chemoreceptor. Central chemoreceptors are basically found in the bones and as well bones and the medulla. So suppose this is a blood, this is a midbrain, okay, midbrain and the medulla. So we have midbrain, bones and medulla. So we have bones and medulla here. Okay, this is a medulla. Suppose. So central chemoreceptors, we have to remember only one two things. That is, a central chemoreceptor respond to proton and carbon dioxide. Central chemoreceptor does not respond to oxygen, particles of oxygen. So central chemoreceptor does not respond to the oxygen. So that is why carbon dioxide is so much important for us to drive the respiration, because this is the carbon dioxide which can reach the plasma, which can just cross the blood-brain barrier, and it can reach inside, and it can dissociate into S plus and bicarbonate, and it will. This is the proton and the carbon dioxide, which are the main determinants of the which are the driving force for the respiratory system, and if so, that is the reason why we should not give 100% of oxygen, so to maintain some amount of driving force into our circulation. So second is the peripheral chemoreceptors. I think I will also talk about a small thing about this is the level of C3, this is the level of C5, C1, C2. Okay. I think we'll this will be covered in the orthopedics, but suppose we have a spinal injury. Suppose we have an injury, not is main basically spine, but if there is if there is some problem between the bones and the medulla, okay. If the communication between the bones and the medulla is lost, then that will result in the uh, de-arrangement of the de-arranged breathing patterns. Okay, breathing patterns. So what can be the various type of breathing patterns? Okay. So first breathing pattern I would like to talk about is the apneic breathing. Apneic breathing. Apnea. That means there is no breathing at all. Okay. So suppose this is the reason Borzinger complex. This is the pre-Borzinger complex. Pre-Borzinger complex. Suppose this is the region which is destroyed, then there will be the apneic breathing, that is apnea. Okay, that is there will be the apnea, then there will be some breathing, then there will be apnea, some breathing, apnea, breathing. This is called the apneic pattern of the breathing. Okay. Second type of breathing we see is the same stroke breathing. This is like in the breathing continuously increases, then there is apnea, then again it increases. This is called stroke breathing. This is most commonly seen in the cases of anything that results in the damage to the midbrain, or in case of congestive heart failure too. We can see the stroke breathing. So these are the patterns of the breathing. Okay. So if anything happens between the C3 and C5, as I have mentioned that all the muscles of respiration, are skeletal muscles. So what is the importance of saying this is that skeletal muscles can fatigue. So although I can breathe, but these skeletal muscles can fatigue. So if there is any deformity in this communication with the skeletal muscles, then the breathing will be changed. That is C3 and C5. C3 to C5 is the part which supplies the diaphragm. Diaphragm. So this will hinder the normal respiration. C3 and C5 which innervates the diaphragm. So these are basically the just the motor neurons. These are just the basically the motor neurons. Okay, but if there is some defect in the C3 to C5, then the diaphragm cannot be innervated, and if diaphragm cannot be innervated, then main muscle for the respiration cannot be innervated, and obviously the breathing will be deformed. Second type of chemoreceptors I would like to talk is the peripheral chemoreceptors. So peripheral chemoreceptors are present in the carotid bodies and aortic arch. They are like nerves, carotid body and aortic arch. Peripheral chemoreceptors, they can respond to oxygen. They can respond to carbon dioxide. They can respond to oxygen and carbon dioxide and pH. But this response to the carbon dioxide and pH is lesser, okay, than the central chemoreceptors. So another important factor I want to impose is that the peripheral chemoreceptors are those which can respond to the oxygen content of the blood. And when they sense that the oxygen content is lesser or more, then they will provide the information via two knobs. One is the ninth knob, that is the glossopharyngeal knob, and second is the 10th knob, that is the vagus knob. So the way does this basically goes? This will go like 9 and 10. These peripheral chemoreceptors will provide the information to the central chemoreceptors. Okay, this will provide the information to the central chemoreceptors. So peripheral chemoreceptors respond to the oxygen content of the blood. Now let's talk about a small deal about high pressure environment. Suppose high altitude. Suppose let us talk about the high altitude. What happens in the high altitude? Uh, as I go in the high altitude, high altitude, the amount of inspired oxygen will be less. Okay, that means the partial pressure. That means the amount of partial pressure will be less. Partial pressure of oxygen will be less. Okay, so that means to increase the amount of oxygen content, and I will have instead of hyperventilation. Okay. Okay. First, my sorry. First, oxygen will be less. Okay. Now, initially I will have a hypoventilation because I cannot ventilate my alveoli. So that will create the carbon dioxide will be more. Okay, carbon dioxide content will be more. Okay, that means the acid amount will be more. Okay, initially the acid amount will be more in my circulation. Then I will hyperventilate and I will throw out this acid. Okay, but as the acid level will be lesser and lesser, I will have more of the bicarbonate. That is, I will have the respiratory alkalosis. So who will balance this respiratory alkalosis? My kidney. Okay, my kidney will throw out the bicarbonate out, and this is how I achieve the acclimatization. Okay. So what happens in the high altitude is initially oxygen is inspired oxygen is less, and then that's why initially I am hyperventilating, and initially carbon dioxide will be more carbon dioxide. Because of the carbon dioxide, the content of the carbon dioxide, this will lead to the hyperventilation, and the hyperventilation will lead to the washing out of the carbon dioxide, and that is the just throwing out of the protons, and the bicarbonates will be retained more, and that will lead to the respiratory alkalosis. Respiratory alkalosis should be balanced by the kidney, and that is how I threw the bicarbonate. First is the metabolic change. Second, I can have is a pulmonary change. Pulmonary change when I reach the high altitude. Why does this happen? Because we know that the pulmonary circulation goes into the vasoconstriction, once there is the partial pressure of oxygen is less. If the partial pressure of oxygen is less, then the peripheral circulation goes into vasoconstriction, whereas the systemic circulation goes into the vasodilation. So that is the reason when in the high altitude the partial pressure of oxygen is less. So that's why all the pulmonary circulation will go into the vasoconstriction. This will lead to the pulmonary hypertension, and this will lead to the pulmonary edema, pulmonary effusion and edema. Okay, edema, and this will lead to the edematous lung, and that is another important concept: high altitude pulmonary edema, HAP, which is the life-threatening condition. Okay. High altitude cerebral edema is another concept. This is a cerebral edema. We don't know much about what causes it. But it is said that because of the more of the same reason as that of the pulmonary how the pulmonary changes occurs. The similar changes occurs in the in the cerebral circulations, and that can lead to the edema in the cerebral circulation too. Okay, that is the little concept about the high altitude. Now, finally, we will go into the another important topic, and I think we will conclude this. Okay, we'll go into the very important topic, that is a ventilation perfusion mismatch. And we will conclude this topic. Okay. So this is the alveoli, this is the lung. As I have mentioned that the intrapleural pressure is -5, but this -5 pressure is the mean intrapleural pressure. This intrapleural pressure changes from -10, -5, -2.5. So from apex to the base, as I go from apex to the base, the intrapleural pressure changes from -5, 5, and -2. That means it becomes more of a positive. What is the clinical importance of this is that if my intrapleural pressure is -5, that means my transmural pressure is 10, 5, 2.5. What it means is that the alveoli in the apex, middle region, and the base, if I see these three regions, then the alveoli in the upper region will have more intrapleural pressure. That means they are more distended. Lower will have little distended and small pressure. Okay. So that is the basic differences between the intrapleural pressure within the alveoli. So this will lead to this difference in the intrapleural pressure will lead to the difference in the ventilation. So it is very important, very easy to understand that the ventilation can be highest in the ventilation is highest in the base. Perfusion is also highest in the base. Why perfusion is highest in the base? Because this is the lung. Suppose this is the circulation going. Due to the gravity, due to the effect of gravity, this is arterial, this is the venous side. Okay. In the upper regions, due to the effect of the gravity and all this, these upper airway, upper blood vessels are constricted. Okay, this is constricted. This is more of a dilated, and this is very much dilated. Okay, because the partial pressure of arterial pressure is very high in the lower regions. So that is the reason. If the arterial pressure is high, then this will easily pass from this alveoli, and the partial pressure of arterial pressure is lesser here. Partial pressure of artery is very less, so that will compress the blood vessels. So that is the reason why the perfusion is also highest in the base. So perfusion is highest in the base. Ventilation is highest in the base. So what is the clinical importance of these? Okay. So in the base, I have more of a ventilation. Okay. That means the carbon dioxide wash out is more. Okay. That means the oxygen content is less. Okay. So oxygen content is least in the base, whereas in the apex, ventilation is less, carbon dioxide wash out is less. So carbon dioxide wash out is more. That means ventilation is more. So that means I have to wash out the carbon dioxide. Okay, ventilation more. That means this is the hyperventilation here. This is the hypoventilation. Okay, less ventilated area, apex. So oxygen content is more. What is the clinical importance of oxygen content is more in the apex? Because the oxygen content is highest in the apex, so we have the tuberculosis bacteria, TB seen in the apex of the lung, because these are the aerobic bacteria, and this aerobic bacteria loves oxygen. So the TB is highest in the apex of the lung because of this fact, because the oxygen content is highest in the apex of the lung. So now let us talk about ventilation, perfusion. Okay, let's talk about ventilation and perfusion. So if ventilation and perfusion equals to 1, that means ventilate if one area, suppose this is the area of the lung, which is properly ventilated from the alveoli and properly perfused. Okay, so ventilation perfusion is 1, that means ventilation equals to perfusion. This is the ideal state. Okay, so how this will change, ventilation perfusion will change over the regions of the lungs. Let's see. So suppose this ventilation perfusion is 1, I have none. So what will happen in ventilation in the apex, and what will happen in the base? So in the apex, although the perfusion is less and ventilation is less, but the ventilation perfusion is greater than 1, whereas in the base is less than 1. Why does it happen? Because in the base we have more of ventilation, we have more of perfusion, but ventilation is so much high that the perfusion cannot match the ventilation. So ventilation is lesser than the perfusion in the base of the lung. Okay. Whereas in the apex of the lung, although the perfusion is less, but although the perfusion is relatively less, but the ventilation and perfusion is typically towards the higher side. That is, ventilation is uh, greater than perfusion. So this is how the ventilation and perfusion changes over the apex and the basis of the lung. So now let us see the extremes of the ventilation and perfusion. Okay, extremes of the ventilation and perfusion. So that means, what is the extremes? Like ventilation perfusion equals to 0. That means it means that the ventilation is 0. That means there is no ventilation, no ventilation, no ventilation. There which can occur, which can occur obstruction. Suppose we have an obstruction, complete obstruction of the alveoli, complete obstruction of the bronchus or alveoli or anything, then that can lead to the ventilation perfusion 0. Ventilation perfusion lesser than 1. Okay, that means ventilation is less but perfusion is high. This is the very much extreme case. Okay, this means the perfusion which was coming from the blood is wasted. So this is called perfusion wasted. Ventilation 0, that means perfusion is just wasted. Little less from this extreme condition can be ventilation perfusion less than 1. Okay, less than 1. That means from 0 to 1. 0 to 1. That means there is no complete obstruction. There is some obstruction but no complete obstruction. Like can have in we can have in asthma, we can have in foreign bodies. Okay. In any cases of airway obstruction, there can be the ventilation perfusion ratio can be lesser than 1. Okay. So it's like the ventilation is like the perfusion is this. Second is ventilation perfusion equals to infinite. That means the perfusion is 0. That means there is no perfusion. That is ventilation is wasted. Is wasted. That means the alveolar was ventilated, but the perfusion cannot happen. Why the perfusion could not happen? It could be due to some kind of pulmonary embolus, some kind of pulmonary hypertension, any kind of obstruction in the pulmonary circulation can lead to the perfusion being 0. But this is very extreme case. This can be ventilation perfusion, okay, is greater than 1. That is, this is the case. That is, the ventilation is more for the perfusion than the perfusion. Okay, this can happen in the cases of pulmonary embolus and the pulmonary hypertension and everything. So this is the basic concept of the ventilation and the perfusion. Okay, how ventilation is wasted, how perfusion is wasted. So that means if I can say that if there is no ventilation at all, no ventilation, that is ventilation is 0, that means PQ is 0. That means all over the blood that comes from the venous side, to the arterial side is shunted. That means there is no gas exchange. So this is the case like we have shunt. Suppose ventilation perfusion is infinite. That means perfusion is 0. Perfusion is 0 basically means there was alveoli, there was blood flow was happening, but the blood flow is obstructed. So ventilation perfusion infinite means there is ventilation but no perfusion, which means it became like a dead space. This region became like a dead space because the alveoli cannot exchange the gas. So these are the two extremes. One is the shunting and one is the dead space. So if I plot a graph, ventilation perfusion 0, ventilation perfusion infinite, So ventilation perfusion 0 means I have a shunt, and ventilation perfusion infinite means we have a dead space. And we have already talked that this dead space is now a physiological dead space. Yeah. Total dead space is physiological dead space plus anatomical dead space plus, but in normal person we only have anatomical dead space. But I have already mentioned in that lecture also, I mentioned that if there is a ventilation perfusion mismatch, there can be a physiological dead space, and that will increase the total dead space in a person. Okay. Yeah. Uh, Let me talk this last concept about hypoxic vasoconstriction and how it is beneficial, actually beneficial for us. I told that if the oxygen content is less in the blood, then the pulmonary circulation goes into the vasoconstriction. Okay, but how is it important for us? Because suppose this is the region where there is no suppose there is no perfusion is less, suppose the perfusion is good. Suppose this is perfusion is less, then the pulmonary circulation goes into vasoconstriction. This will divert the blood to the better ventilated area. So vasoconstriction of the alveoli is a important phenomenon to help divert the blood, divert the perfusion to the region where the ventilation is high. Ventilation is good. Region where ventilation is good. Okay. Okay. Uh, Little small deal about causes of hypoxia. What can lead to a hypoxia? First, suppose cause of hypoxia. First, the inspired oxygen is less. The diffusion, there is some problem with the alveoli. The alveoli blood interface, as we have mentioned, is defective because of thickness, because of defect in the surface area, okay, or the amount of oxygen coming is less. That can be due to the deficiency in the hemoglobin, okay, defects in the hemoglobin, okay. I also want to mention that hemoglobin and carbon dioxide is a deadly combination, because carbon dioxide hemoglobin loves to bind with the carbon monoxide than the oxygen. So if there is carbon monoxide in the blood, then the hemoglobin will bind to the carbon monoxide of one. Okay. Second, when the hemoglobin is bound to the carbon monoxide, the unloading of the oxygen is further impaired. So it will do damage in the two step. That is, first it will bind with the hemoglobin, and second it will hinder the unloading of the oxygen to the tissues, and this will lead to the more of the hypoxia. So more the oxygen is less, hemoglobin defects in the hemoglobin. At the level of the tissue, there can be like as I mentioned, carbon monoxide defects. Okay, and there can be various ventilation perfusion mismatch. Like there can be shunts. There can be circulation defects. There can be emboli. There can be lung defect, as I mentioned. Okay, there can be dead space, or there can be intermediate between the shunts and the dead space. So last thing, if we have to manage the hypoxia, management of hypoxia. Last one, management of hypoxia. Then first, in all the cases, increasing the oxygen, inspired oxygen is helpful, except in case of shunts. Why? Because in the case of shunts, suppose this is ventilation was good, but perfusion ventilation was bad, but the perfusion was quite good. So in the case of shunts, the diffusion doesn't happen, and thus shunts. In the case of shunts, they are not very much useful to have increase in the oxygen content. Okay, so this is all for the respiratory physiology. Thank you. Please like, share, and subscribe. Okay, bye bye.